A myocardial infarction, commonly known as a heart attack, is a severe event where blood flow to a part of the heart muscle is suddenly and significantly reduced or completely stopped. This critical blockage starves the affected heart tissue of essential oxygen and vital nutrients, which can quickly cause irreversible cellular death if not promptly addressed. Understanding this complex process is absolutely essential for effective prevention, early detection, and successful treatment across the board. To grasp what a heart attack is, we first must appreciate the heart's incredible role as the body's powerful, continuously working central pump. This muscular organ functions with 4 chambers, specifically the 2 upper atria and the 2 lower, much stronger ventricles. The left ventricle, possessing a very thick muscular wall, bears the significant responsibility of pumping oxygenated blood out to the entire systemic circulation. The heart muscle itself, known as the myocardium, has an extraordinarily high demand for energy, necessitating a constant and totally uninterrupted blood supply to function correctly. This life-sustaining blood flow is meticulously delivered through the coronary arteries, a complex network of vessels spread across the heart surface. The 2 main arteries, the left and the right coronary arteries, branch out repeatedly to supply oxygen directly to the hard-working muscle tissue. When any of these crucial arteries become narrowed or completely obstructed, the affected myocardium suffers from oxygen deprivation, a state called ischemia. If this severe ischemia persists for too long without relief, the result is the tragic event we call a myocardial infarction. The most frequent underlying culprit behind most heart attacks is atherosclerosis, which is a slow, progressive disease affecting the body's arteries. Atherosclerosis develops silently over many years as fatty deposits, appropriately termed plaques, begin to build up inside the artery walls. These complex plaques are a mixture of cholesterol, fats, inflammatory cells, calcium, and other circulating blood components, accumulating over time. As these plaques continue to grow and harden, they gradually constrict the artery, slowly restricting the normal flow of life-giving blood. While many people carry these plaques without any noticeable symptoms, the situation becomes extremely dangerous when a plaque deposit becomes unstable. A heart attack most commonly precipitates when one of these fragile atherosclerotic plaques suddenly ruptures or cracks open unexpectedly. The body interprets this rupture as a significant injury to the inner vessel lining and immediately triggers the clotting cascade in response. Platelets and various clotting proteins rapidly gather at the damaged site to form a new blood clot, known medically as a thrombus. A partial blockage from this newly formed clot can cause significant chest discomfort known as angina, signaling trouble ahead. However, a complete blockage by the thrombus suddenly cuts off all blood flow, culminating in a full-blown myocardial infarction. Once that critical blood flow is severed, the oxygen-starved heart muscle cells immediately begin to experience profound metabolic stress and malfunction. After only about 20 to 30 minutes without any oxygen, the damage shifts from stress to being truly irreversible, and the tissue starts to die. This rapid timeline highlights precisely why immediate medical intervention is the single most critical factor in saving heart muscle tissue after an event. The clinical symptoms signaling a heart attack can vary greatly from person to person, but the classic hallmark is usually intense chest pain or pressure. This notorious pain is frequently described as a deep tightness, a crushing squeeze, or an overwhelming heaviness centered in the chest area. This agonizing sensation often lasts for several minutes, sometimes coming and going, and it commonly radiates outward to other body parts. Pain often travels down the left arm, up into the jaw, across the neck, or sometimes into the upper back and abdomen. Other frequently observed signs include sudden shortness of breath, profuse sweating, often described as clammy or cold, and feelings of nausea or actual vomiting. Patients might also experience dizziness, lightheadedness, noticeable heart palpitations, or an overwhelming sudden sense of impending doom and anxiety. Crucially, not every heart attack presents with obvious chest pain, as so-called silent heart attacks can occur, particularly in certain patient groups. These silent events might only manifest with subtle symptoms, like unexplained chronic fatigue, mild shortness of breath, or indigestion, like discomfort. Once heart tissue begins to die due to the blockage, the body immediately initiates a highly complex and coordinated inflammatory response to the injury. Dying and damaged heart cells actively release specific chemical distress signals that attract key immune cells, such as neutrophils, to the injury site. These recruited immune cells work to clear away the dead cellular debris, yet their presence also contributes to inflammation that can temporarily increase the local damage. As time progresses, the body transitions into a necessary healing phase where the non-functional heart muscle gets progressively replaced by tough, fibrous scar tissue. While this scar tissue is vital for maintaining the heart's physical structure, it cannot contract or conduct the necessary electrical signals, like healthy muscle. Consequently, the heart's overall pumping efficiency may become permanently reduced, potentially leading to long-term complications like heart failure or irregular rhythms. The overall extent of permanent damage sustained during a heart attack is determined by several important contributing factors that must be considered. Key factors include the exact anatomical location of the arterial blockage and the actual size of the specific artery that has been affected. Furthermore, the total duration of the blockage, which dictates oxygen deprivation time, plays a massive role in determining tissue loss. The presence or absence of collateral circulation, which means alternative smaller vessels, can also partially supply blood to the endangered area. Finally, the speed and quality of the subsequent emergency medical treatment a patient receives significantly impacts the final outcome. For instance, a blockage in a major vessel, like the left anterior descending artery, can cause extensive, potentially fatal heart damage. Conversely, an obstruction in a much smaller branch artery might only result in more limited and localized injury to the muscle. Confirming a heart attack, diagnosis demands immediate and thorough medical evaluation by trained professionals in an emergency setting. One of the very first diagnostic tools utilized is the electrocardiogram, or ECG, which meticulously records the heart's electrical wave patterns. Specific, recognizable changes in the ECG tracing can strongly suggest a heart attack is occurring and help pinpoint its general location. Blood tests are also an indispensable part of the diagnostic process, requiring doctors to measure specific cardiac biomarkers released into the circulation. The most important of these biomarkers is troponin, a protein that floods the bloodstream when heart muscle cells have suffered definitive injury. Elevated troponin levels provide very strong objective evidence, confirming the presence of myocardial injury requiring immediate action. Other advanced tests, like an echocardiogram, which is an ultrasound of the heart, assess the remaining pumping function and wall motion abnormalities. Coronary angiography is another crucial imaging procedure used to precisely visualize the coronary arteries, using injected contrast dye to find the exact spot of the occlusion. The entire treatment strategy for a heart attack is intensely focused on one primary goal: rapidly restoring adequate blood flow, a process termed reperfusion. In many modern medical settings, the preferred initial intervention is primary percutaneous coronary intervention, more commonly known as angioplasty. This elegant procedure involves guiding a catheter through a peripheral artery, usually in the wrist or groin, directly up to the blocked coronary vessel. A tiny balloon on the catheter tip is then carefully inflated to mechanically compress the blockage and physically push the plaque aside. Following this opening, a stent, which is a small, expandable metal mesh tube, is permanently placed to actively hold the artery open for the long term. If the advanced angioplasty equipment is not immediately accessible, physicians may administer specialized thrombolytic medications designed to dissolve the existing blood clot. These powerful clot-busting drugs are most effective when given to the patient within the crucial first few hours following the initial onset of symptoms. In addition to the physical restoration of flow, patients immediately begin a course of supportive medications to stabilize their condition. This regimen almost always includes antiplatelet drugs, like aspirin, to significantly prevent the formation of any new or subsequent clots. Patients are also frequently prescribed anticoagulants or blood thinners to actively reduce the overall risk of forming further dangerous blockages elsewhere. Beta blockers are given to lessen the heart's overall workload and to help protect the damaged tissue from electrical instability and dangerous arrhythmias. Statins are administered to aggressively lower high cholesterol levels and, importantly, to help stabilize the remaining vulnerable arterial plaques in the system. ACE inhibitors, or similar blood pressure medications, are added to help protect the long-term function of the recovering heart muscle. The body's immune response after a heart attack is quite complex, playing a dual role in the critical healing process that follows the initial insult. While initial inflammation is absolutely necessary for clearing debris, unchecked or prolonged inflammation can unfortunately cause secondary damage to surrounding healthy tissue. In the later stages, the focus shifts toward a controlled reparative phase, promoting the formation of scar tissue and necessary structural remodeling of the organ. Scientists are intensely researching methods to better regulate this delicate immune response, to ultimately foster superior healing outcomes and prevent later heart failure. Several serious complications can arise following the acute event, including persistent heart failure due to overall weakened pumping mechanics. Life-threatening arrhythmias, which are abnormal heart rhythms, remain a significant concern, especially in the immediate recovery period following the injury. Cardiogenic shock, a dangerous and profound drop in systemic blood pressure caused by heart failure, is another potentially fatal complication. Furthermore, there is always the risk of new blood clots forming inside the heart chambers, or even damage occurring to the heart's delicate valve structures. Prevention remains the single most powerful and important long-term strategy in effectively managing the threat of myocardial infarction across populations. Many significant risk factors associated with heart attacks are entirely modifiable through lifestyle changes and medical management strategies. Key modifiable risks include having high untreated blood pressure, elevated unhealthy cholesterol levels, and actively smoking tobacco products. Obesity, insufficient physical activity, uncontrolled diabetes, and a poor diet are also major contributing factors that elevate an individual's overall risk profile. Adopting a genuinely heart-healthy lifestyle can dramatically lower the probability of experiencing a heart attack in the future. This involves eating a balanced diet rich in fresh produce, whole grains, and lean proteins, while diligently managing and reducing chronic life stress. Unlike bacterial infections, there is no vaccine we can take to prevent a heart attack, but modern cardiology offers incredibly effective tools. Medications like statins and antihypertensives, alongside continuous advances in emergency care and interventional techniques, have significantly lowered attack severity and incidence. Survivors often face significant emotional and psychological hurdles post-event, including anxiety, depression, and a persistent fear of recurrence. Cardiac rehabilitation programs are absolutely crucial in recovery, combining monitored exercise, nutritional guidance, and vital psychological support. These comprehensive programs empower patients to regain physical strength, rebuild their personal confidence, and ultimately improve their long-term quality of life. On a broader scale, heart attacks place a massive ongoing burden on our global healthcare systems due to medical costs and lost economic productivity. Therefore, robust public health initiatives focused on promoting widespread cardiovascular wellness and reducing population risk factors are absolutely essential for societal benefit. In closing, a myocardial infarction is a complex and dangerous cardiovascular emergency stemming from a sudden and total cessation of heart muscle blood supply. It involves intricate biological processes spanning the cardiovascular system, the immune response, and crucial healing mechanisms all working in concert. Deep understanding of its root causes, recognizing the symptoms, employing rapid diagnosis, and utilizing modern treatment is key to mitigating its devastating impact. Through continued medical breakthroughs, better preventive lifestyle choices, and unwavering commitment to fast emergency response, the terrible consequences of heart attacks can be successfully minimized.